Go ahead.
Great. Well, thank you, Blake, and glad we could be here today. We're going to be talking about, as I said, my name is Linda Jones. I'm with Marsh McLennan, with the healthcare leaders here. I'll be talking a little bit more about Marsh McLennan, what all it includes, but I want to introduce myself as well as my colleague, John Derse, who is from Mercer. Many of you have heard of Mercer, but we work together. And I'll have John introduce himself further, but to do anything related to risk is from my perspective, and whether that is healthcare staffing or, financial exposures, and what we're saying of what's happening in the healthcare world these days for anybody related to working in that space. It has changed so much, and as we see new models being developed for healthcare delivery, it's important to consider what the changes are expected and how this business is changing from a staffing standpoint, where there's physicians, nurses, and we'll be talking about the state of the problem, which everybody knows, as well as considering options for improvement, and that's the transformation. So John, you want to tell a little bit about yourself?
Sure. Yeah. Thanks, Linda. John Derse, and I'm responsible for Mercer's healthcare industry vertical. And about a decade ago, we started the vertical because two reasons, really. It's such an enormous part of our portfolio here in this country. We have worked with roughly 450 different health systems, and with Mercer, $1 out of every 10 we take in comes from either a hospital or health system. So we're all in from that perspective with clients. And then the level of disruption, it didn't take a genius to figure out that this is an industry that was headed for an enormous amount of disruption and change, and much of it very promising, and much of it also incredibly challenging. Then, of course, here comes the pandemic, and everything else now changed. But the focus of Mercer is really on people and organization. So, it's funny, before we got started, we were talking about the ecosystem and the breadth of it across healthcare. And I think Linda and I are really good examples of that, where years ago, we would not have necessarily connected anywhere near as closely as we are, but there's such a huge and tight connection between what's happening in healthcare now and how the risk profile changes, and how all of these things need to be considered as organizations disrupt and as they transform, and as they move forward. So, it's going to be to just focus on the state today of nurses and physicians is not what we wanted to do. We're going to talk about that. We're going to share our insights, and we're going to share some data and some research, and I think, hopefully you'll all find it interesting. I don't think there's any new news here, but what we want to really also focus on is this notion of transformation, which is something so critical, in terms of, we think of it as a way out or a way forward. One of our favorite clients, Houston Methodist, the Chief Innovation Officer there is a woman by the name of Roberta Schwartz, and she's made her line famous, which is innovation is the only way out. We only slightly change that when we say transformation is the only way out. But looking forward to the conversation today, and also, since we're such an intimate group, by all means, just stop us if there are questions or challenges, or how certain things that we're going to share apply, and we'll have a discussion, which should be fun. So maybe Linda, back to you, and tell me if you want to move the slide.
If we can move to the next slide, that'd be great. So again, just a little bit about Marsh McLennan. So Marsh McLennan, many of you have heard of, is the parent organization. Then we have 4 sister companies within that. Mercer, as John's described, Oliver Wyman, which provides management advisory consulting services, as well as actuarial services. And they also have a healthcare division. We work closely with them. Marsh, as I mentioned, we provide insurance brokering and advisory services to anything related to healthcare. And then Guy Carpenter, which is our sister reinsurance broker. So as we look at these opportunities for, self-insurance, they provide that specialty self-insurance. And sometimes that's, employer stop loss, that is provider stop loss, for the large managed care, for the large ACO type risk and provider organizations, as well as medical malpractice insurance, reinsurance for these large insurers. So we all have a healthcare division. We all work closely together. One of our biggest areas of focus right now is value-based care, because there's such a, cross-disciplinary approach to that, which we can, work with those organizations to try to manage that risk. Okay, next slide. So as John said, and I'm going to be turning it back over to him, we all hear the problems of what's happening in healthcare now. We're all feeling it. It's beyond the shortage of just physicians and nurses and support staff. One thing that Mercer has provided that we use a lot of is this data analysis, survey data, where they go out and research what the employees are thinking, projected changes in staffing, availability, capacity by county in the country. And this is very important as we all see and hear stories about challenges and how this business is transformed. And I talk about the change in physician business. Some are saying that, more of a commodity. Physicians, don't like that. I don't necessarily like that either. But we're seeing this change from, and I work with many of these staffing organizations where, people are not hanging their shingles, as you know, and moving more towards a staffing model where they can have more control and be more of a gig economy type worker and move around and work in different parts of the country at different times of the year. So I'm going to turn this over to John, and we're going to be kind of jumping in back and forth, talking a little bit initially about the state of the problem and then areas of improvement and what we see work to try to manage that variation of risk and fluctuation of capacity. So John?
Yeah, thank you, Linda. So what we're looking at here is really, this is a slide that we use very frequently with clients today. It's hard to have any kind of conversation with a healthcare provider that doesn't level set, at least at the onset, around what are we up against and for how long. So I think what we're trying to do here is, absolutely insufficient labor supply is real. It's here to stay. And these are all stats. I'm sure that, that many of you've probably seen many of these, but from the physician shortage, right on down to the lowest paid, low wage workers in healthcare, all are critical in this machine and how it works. And as there are shortages and as there's problems related to burnout and ability to deliver, it's a ripple effect across the whole system. So Mercer has spent a great deal of time on analytics, and we're just in the process. We're probably 3 weeks away from finishing our most recent update of labor in the United States for healthcare workers, and we'll talk about that. But where we're a little different than the Bureau of Labor Statistics and some of these others is that we project both some demand and supply. So when we look at the labor supply, there's been a couple of articles of late. Becker's, I know, made a big deal out of one of them, which I was really surprised to see, where they talked about the increase in nursing and how looks like we might be out of the woods. Things are looking better. The supply is back up to where it was. And, we didn't really know how to respond to that directly, but I can assure you we are not out of the woods. And the issue is when you're looking at these kinds of positions, it has to be considering both supply and demand, because yes, the supply is up. There's no doubt that the paper was correct on that front, but you have to take into account the increase in demand, which is significant around aging and the greater access to care, the demand for care here, there, and everywhere. So I mean, it's still an enormous problem. We expect these numbers to go up some when we bring our numbers out next month. But huge issue, and it's a pendulum that is not swinging back. So many of our clients feel that this too shall pass. It always has. It's not. And I think that's where we're coming down on there has to be a different way of operating, thinking about technology different, thinking about data different, thinking about everything different, including the way people work together and the actual work they do. So we're going to talk about that a little bit more. Our sister company, Oliver Wyman, on the, that Linda touched on the previous slide, put a paper out not too long ago, which we spend a lot of time with, just making sure organizations know that the current cost models are not sustainable. If organizations can't take OpEx down 20% over the next 5, 6, 7 years, they're just our view is that it's just not, they're not going to be viable. And when you think about labor costs in the typical hospital, again, I know we're not, the group today is not all necessarily hospitals, but typical OpEx in an acute care setting is somewhere between 50 and 60% of total OpEx. And if you think you're going to take 20% out of labor costs, you really need to think long and hard about how's that going to work. What we need to do, and this is where a client in the Midwest, where we're involved with a large, very well-known academic health system, the CEO finally in the middle of the meeting was like, hey, you know what? The math doesn't work and it won't work. So again, systems are beginning to realize we cannot just continue the way we are and try to do things a little faster and a little cheaper. We really do need to change how we think and how we work. And on the burnout front, if we don't, the people that are thinking about leaving will leave and they will not return. Working in healthcare is exceptionally difficult and it is exceptionally dangerous. And we're going to share some of the incident and accident injury rate, and it's extremely troubling. So burnout is taking a toll, but it's going to get worse, not better, unless things are done. And things can be done. And again, we want to get to that. We don't want to dwell on this for the whole time we have together. But before I leave this slide, any thoughts, challenges, questions from anybody? I know we have a nice small little team here. So if you have a question or thought, please share. Or not.
Well, the one thing too is to add to that is we aren't seeing it quantified yet, but it's definitely an implementation phase, is the implementation of AI. And as we're seeing in the tech world, what that's doing to employment numbers there, we're not going to see necessarily changes in patient care, but we're definitely seeing a retooling of everything that's happening. So we'll expect, the billions of dollars have been invested by private equity just in 2023, shows that momentum and that train is going fast. So we'll definitely see more of that in the future too.
Yeah. And a lot of this,
and
sorry,
Summers. Yeah.
Sorry. Yeah, just one quick comment. And sorry, I'm in transit. I'll be back in front of my computer before this ends. But 2 comments. I actually started my career at Oliver Wyman working in their health and life sciences. So yay, Marsh & McLennan Company.
Yay.
But also a question on, I guess, the third pillar here around redesigning jobs for sustainability. After Oliver Wyman and before I came to the Christensen Institute where I am now, I worked at Atrium Health, and one of my projects before I left amidst COVID was around provider burnout. And, like at every large health system, they're trying to tackle this. And you call out redesigning jobs for sustainability. How much of the conversation with C-suite leaders is around actual culture change versus just at the job definition level or at the individual provider or individual teammate level? And I ask that because a lot of the research shows you can't really put the onus of a systemic problem onto the individual and hope that it will get better. We're not going to yoga our way out of burnout. We're not going to self-care our way out of burnout. Right. So I guess my question here is really around, are you seeing leaders lean into an organizational culture change and culture shift versus just tweaks to the existing status quo to try and make it marginally better?
That's a great question. And my answer is a resounding finally. Yes, the leading systems and leading members of the C-suite are. In fact, an example that we're going to share here in a couple of slides goes right to that, where we're in the midst of, this is work we're doing right now, again, for an upper Midwest large academic health system. And before the work redesign, is being, it was done, there was a deep dive into the organizational readiness, into the cultural elements, into those things that absolutely need to be understood before we try to bring these kind of changes forward and begin to work on those areas. And you'll see it gets a little bit more clear when we show the slide, but it's a great point. And I think it's one of the big learnings we've had, which is if we don't have the real move around the organization and its capacity to change, and we don't think about this work reflecting that, then your likelihood of success is greatly diminished. And the flip side of that, it's greatly enhanced if, because if we can take 2, 3, 4 jobs and that can be successful, it establishes momentum. People want to and lean into moving forward with some of this. And again, what we're talking about is in the case, for example, of a CMA. And in one system where we completed some work recently, the tasks for that particular role were numbered 42 different things that this individual role accounted for. When we began to break it down, 17 of them required no certification. Another 17 or 18 could be automated and or moved down, certainly to lower levels, which left a much smaller set of tasks and expanded dramatically the number of nurses that individual could cover. And we created a new role that was not certified. So, I mean, I'm not saying that's the fit for everywhere, but the things we're finding and the opportunities for automation and redesign are plentiful. But again, the importance is we've got to pay attention to, what's the state of the organization today, and what are those things that have to be dealt with simultaneously, or we're not going to get it done.
Actually, I have kind of sorry, if Anne, you had a response, I can wait on my question.
Okay.
No, you can go.
Oh, cool. Yeah. So I guess like an extension of that is I feel like we hear a lot about the physician shortage, and then on the nurse side, shortages there. But I feel like what goes a little counter to that is the growth in mid-levels in terms of NPs and PAs. I guess how does long-term that factor into the overall supply? Because if some of the amount of work that like physicians have to do kind of goes down, then like that shortage may not be quite as much of a problem.
And technology too. If you can do a 12 lead EKG on an iPhone, remotely, versus the person having to come in, that plays a role too. But go ahead, John.
No, I think that's a great point. And this is why we're not necessarily shouting from the mountaintops that, this is terrible, it's never going to get better. There are opportunities. And I think what you state is really a good one. But then again, we have to really be clear on, how does this actually play out? How are they being accepted? How well does this and their work integrate in with what we're trying to get done as a system? Does this individual role, are they doing more on testing or less or more cautious, perhaps driving cost or utilizing resources greater because they're not an MD? Again, these are things that we're learning as we go, but I would say that our point of view on this thing is that it will work. It will absolutely impact how and what we get done, and how we do that with physicians and with all the positions that leading up to that. So I think there's hope, but the other side of that is this has to work. It absolutely has to work. So that sort of changes the formula a little bit when you think about how we want to create these and integrate and get these folks working together. Same thing with technology.
Cool, thanks.
So just to keep us moving, this is, again, I doubt this is news, but it's just the things that are impacting what it's like to work in an acute care setting. And I think even some of the different ways in which care is being delivered today, or it will be delivered, all of these are considerations in terms of how we structure the work and the working conditions, and where we provide assistance where there's not that much or anywhere near enough now. In a couple of slides, Linda's going to talk a little bit about this notion of total worker health and what that means, dealing with the demands of this job, the physical elements, of it and the danger, not just from exposure to hazards, but the danger with people that are under enormous stress, meaning patients and their families, and the things that are so sad to see in our system today. But it's all part of the environment. And these things need to be considered now more than ever when we think about, it's not just, what's contributing to it, but what are the different things that we need to be thinking about that we can do to help the situation. Linda, anything you want to add to that?
Yeah, I mean, you can see the variety of topics here. The one thing about the physical demanding work, I used to manage a third-party administrator that handled workers' compensation claims for healthcare employees. And you talk about, this permanent disability for the older nurses who, can no longer push a bed, and their total worker health. So it all ties in together, absenteeism, but their own health, their mental health, but as John mentioned, their safety health as well. Workplace violence is something very near and dear to my heart. And how we're trying to manage that and what's happened in our unhappy country, as the study just came out, of people being aggressive and feeling, post-COVID obviously increased their ability or their willingness to, confront healthcare providers, and to the point of physical assault. So one area that John talks about too, we talk a lot about shortages for medical assistance, but even for security. Workers that provide security support in an organization are also a challenge. So it all ties together as we address the total worker health, and we'll talk a little bit more about that later.
Yeah. And then just in that lower right corner, the high administrative burdens, little control over schedule. Mercer does this inside employees' minds research every year. We just finished ours a couple months ago, and we do a special healthcare cut, which I'll show you in a minute. But this year, we had an enormous number of folks reacting and responding to the little control over schedule and the demand for flexibility. 82% of all the respondents from healthcare, and this is not specific organizations, we go out to the healthcare workers in this country directly. And the number came back, it was staggering that 82% really, really want greater flexibility and control over their work and their schedules. And while we're on it, let's just take a quick look at this is just one of these slides, the output from this year's Inside Employees' Minds research. But like last year, the financials are still top of the heap in terms of those things that are stressors. So this is a conjoint analysis we do with over thousands of people. And it's not getting at things like benefit preferences or compensation. It's really gets at, what are you worried about? What keeps you up at night? As a healthcare worker, what are those things that give you unease? And, when we went back into the pandemic and did this, clearly personal safety and mental and emotional health, those were absolutely at the top. And they've gone back down to where they have usually been historically. But the issue, I think this is partially a reflection of inflation and and rising costs, but it's ever present. And I think this is where organizations need to understand, we have to pay and pay competitively, but it's so difficult when we think about where we are with the margin issues and the staggering number of not-for-profits across the country that are operating in the red. Which is the great majority of them. And I think that's, of enormous concern. But we're tracking this, and I think, again, it's we're going to start moving to some more positive stuff in a minute. But I think, again, this reinforces that the issues on the workforce and what it's like to work in healthcare have to be understood and then addressed effectively.
And one thing I just want to add to that too is John and I are working with a healthcare organization as we look about their value-based care journey. And one thing that their leader talked about was that 25% of their employees are at or below poverty level in their pay for a health system, which, all all ties into that and their goal of even offering benefits. And how do you offer benefits? I was talking to a general counsel in another health system recently, and he said they recently changed operators for their health system, and the prior operator offered, in lieu of health insurance stipend or contribution, you could get free cell phone use, and they had a high acceptance of people taking the cell phone utilization and compensation rather than having access to health insurance. So it all,
Interesting.
it's all a cycle.
Yeah. Yeah.
Hey, I've got just a quick question on this slide. This is really helpful and interesting information. But I'm really curious. So John, you kind of mentioned you guys kind of look across industries. How does like the, nurse or like clinician's response or healthcare specific response compare to, other industries? Like are there kind of things that like really stick
Dead
out?
last.
Is
Dead.
that right?
That was quick.
Last. And I was debating showing that slide. And there are a couple of industries that aren't too far away, like retail's a little bit above, hospitality, retail a little bit above. But healthcare ever since the pandemic has lagged
Wow.
significantly behind every other industry.
That's pretty damning information.
It is. And again, I think the way I look at this is that, yeah, it's damning, but it is absolutely essential that senior leaders understand this, hear it straight, and know that they absolutely are forced to explore alternatives that to this point they haven't really wanted to, in terms of different ways of working, moving faster, taking risk, really putting operating challenges out there that are different, and then actually focused on execution and holding the organization and themselves accountable for this. And it's, I realize that there are enormous issues when we start doing this work, and there's organized labor, particularly of clinical staff, but there's just no choice but to move these things forward, because they are not going to get better on their own.
Yeah, I was talking to someone at Humana who works in kind of like their nursing department, and
Sure.
I didn't really think about that, but they have nurses, they staff at home health and Centerwell and those sorts of things. And they were saying one of their biggest competitive advantages was kind of like that idea of, more flexibility and kind of everything that they can offer that hospitals are not able to or aren't as good at today. So, just interesting data point.
That's
Sorry,
why you see the growth in the staffing model. When people have to, and this happens to physician, a friend of mine's an interventional radiologist, and we're talking about, going on vacation in July. It's like, oh, I would have had to put that in by February. It's
It's interesting. We just finished some work with, again, well-known Southeastern academic medicine health system, and with a large department with their nurses, with something as simple as we just constructed job sharing, where nurses were able to be 3 days on site, bedside, patient care, 2 days off-site, home, doing either different scheduling or telemed. The turnover went down by 60%. The engagement went up by 90% in that particular group of nurses. Wow. And it was not a tiny group. And it's just, again, it's a little creativity, better systems. This happened to be an organization that was able to leverage Workday. But I mean, UKG, there are systems out there that our organizations, our healthcare providers are moving to, which is enabling a lot more to happen on the flexibility and people side, and less on some of the tedious, really outdated practices that they've had to this point. I'm going to pick up the pace just a little bit, but I do want to make the point I made a minute ago, which is, this pendulum is not swinging back. We're, as I said, about 3 weeks away from refreshing our labor analysis. And what we do is supply and demand across the 50 United States down to the county level for the 85 positions that are in the Bureau of Labor Statistics Healthcare Library. So it's an enormous amount of data, but we use this for so many different work and client assignments, and also just getting a C-suite level of attention. But we're able to drill down, and our last analysis, put out a pretty dismal picture for 2026. When you go out to 2030, it gets a little fuzzy, but we're doing this every 3 or 4 years, and we're really looking forward to what comes out. We'll have big press release and all that kind of stuff, but this is considered one of the best projections of healthcare labor of any, because, as I said, we've been doing this for 40 years and do it all over the world, helping organizations find the talent they need in the different geographies they are exploring. But with healthcare, it's really getting at both the demand and supply, which really is the answer. So where do we go from here? So the math doesn't work. That's, again, one of my favorite quotes that I shared earlier. So we're just going to talk about 4 things that make up a transformation. This is not only these 4 things, but this is actual work now. We're just kind of pulling out work that we're doing with clients or senior executives to try to get the focus on where and what, and not just what to do, but how to get started. And Linda, please interject on any of this when you feel the need. But here's a slide that is usually a pretty good touch point for CEOs, and it's part of a 5-slide deck or so. But when we get to this slide, it usually brings a lot of energy. And again, what we're talking about is responding to the challenges that we've laid out so far. And when we think about what's appropriate, we absolutely need to be thinking about the capacity of the workforce and how to expand it. And what does that look like, and how do we go about it? Everything from the change readiness, organizational readiness, and to your point, and the things we've talked about. And in the middle here, just significantly upping the game around use of data, external data in terms of where the workers are, and internally really getting at root cause. Why are people turning over? Why are people burning out? What makes someone successful and stay and promote and themselves, and what creates other issues related to quality and productivity? And then the other thing we're really finding across healthcare, and again, this is more the case in acute than and post-acute, but not so much in some of the other some of the ambulatory, some of the other models that we're seeing emerge. But this EVP stands for employee value proposition, meaning, why would someone come to work here, and why would they choose to stay? It really goes from the basic fulfillment all the way across the journey of their career to the work itself. And in most of the systems, so many of them that we work with, the EVP just is not fit for purpose any longer. The pandemic changed everything, and it's forcing organizations to think differently about what's it like to work here? What about our work environment? Is it healthy? Is it safe? Is it what people want, or could we be doing better? And the answer certainly to all of those questions is a resounding yes.
And I just want to add too, so, we work with large health systems, academic medical centers, regionals, physician staffing groups, as I mentioned. And one of the projects that John's team recently worked on was a national physician, not a staffing company, but, kind of a physician organization that provides, service on a contract basis. And just studying their turnover. You think a lot of people might leave the hospital setting and move to that more temporary type setting for that control, but they're also facing turnover challenges. And doing a deep dive and interviewing and doing focus groups with those providers and understanding why they've left, had a lot to do with onboarding and training, that they didn't feel engaged in part of a team, which you think that those people would go to that environment because they didn't want to be, so controlled. So it's an interesting role of how that provider is feeling in being accepted or being part of a team. Overall, their value proposition, whether that's in a traditional health system, more of a more modern type provider system, or something more entrepreneurial.
Yeah, good. What we're showing here on this next slide is just when I mentioned that organizations really need to up their game around leveraging data, in this case, workforce data. This is again a sample from an upper Midwest large acute system. And again, we actually do work in the West. I don't know why I picked all these Eastern and Midwest examples, but what we're looking at here is just one role, surge tech. But this is usually just such a huge eye opener for organizations when we go out 4 years or 5 years and are able to show them, look, that lower blue line is where they're going to be with surge techs if nothing changes based on their past and other insights that we have into this system. And the 3 lines above it, the green, the black, and the red, are the different growth projections. But the point we're making here is that if you, in fact, are targeting growth, such as these numbers here, and in this case, these were their numbers from finance, there is an enormous gap, and it's significantly larger than what you think it is. And this is where the predictive analytics come in. But again, this is the rigor of understanding and then leveraging the data fully. There's so much of it in healthcare, and the ability to really get at root cause, the ability to connect the human capital practices to outcomes. It's there. It's been done for years. Organizations need to adopt this and push harder, especially as they move to these more capable systems for tracking, not just the electronic medical record, but having UKG or Workday or Oracle. I mean, it's all the operating and clinical data being brought together to really help understand and tell a story. The lower right is the different states, again, where this particular skill set can be found. And of course, we drill down into counties and help organizations understand that you've got to look farther afield. But while you are, here are some areas really to focus on geographically. And the idea here is to be much more precise and pinpointed. They can do this. And as we improve and close the gaps in workforce, so too, we improve things like turnover. We improve things like burnout, improve things like mistakes and accidents and never events. So it's all tied together, but data is a big deal and one where we're pushing hard, and organizations have done a good job improving their scorecarding and keeping track of, again, I'm greatly generalizing most of the hospitals we work with, but they've really come a long way in record keeping and scorekeeping, but they're not crossing over to do more of the predictive, which is where we're really pushing organizations today, where they just have to be making that move. And this is getting to your question earlier, and this is an example from another body of work, but it is the organizational work we did. Now, Mercer has a tool called ORCA, which is the Organizational Capability Assessment tool, and it is looking at these areas, but it's mostly survey and some interview. But the idea is that we're able to use this to have people describe and discuss where are we as a system? What are those things that work? What are those things that we can rely on? What are those things that are problematic? And this is just the general model, but in the actual case we're going to look at in just a minute, this is how this particular large system came out, where showing if you're red or yellow, or rather orange, this is actually not a very pretty picture. So this was all done in advance of rethinking and redesigning jobs. Initially, they'd come to us to rethink 15 different roles, and we're like, whoa, slow down. Let's make sure we understand what and why. But if we're going to start, what are those roles that would have the biggest and most positive impact, and that we think we can be successful with? So again, I don't want to dwell too much on this, but know that there is a lot of interest in, and there isn't one client that we work with that doesn't see this and understand the importance of it. But again, it's when we're driven by data, when we're talking about what this actual workforce has to say, and points to areas of weakness or concern, I think that ups our ability to be more successful and to move more quickly. So a lot of focus and doubling down on the pre-work and on the change readiness. And I think then when we look at the design, and this is actual output from this particular client, these are the 15 roles. I hope there's just 15 that we'd come up with and they'd come up with around that they really want to focus on and really want to change. The top 4 is where we've started. And the idea there being a combination of what they feel they need to really focus on first, and also where they think they can be successful. And what we've charted here is really where's the opportunity the greatest that we can get to the fastest or the easiest, and where are we going to have a lot more challenge. And again, this was done before we started to roll anything out. But I want to draw your attention to the security officer. You're probably looking at that going, what? Wait a minute. What's going on here? You've got clinical anesthetist, you've got the medical assistant, and security officer. What's that all about? Well, it's really relevant. And we got a big heads up on this one because these security officers themselves were really burnt out. And when we were interviewing them, they were like, more than half were eager to move to the prison system in this particular state and work there because it was safer. There were more rules. You couldn't do anything without staying within a specific guideline or regulation. In this particular system, there was none of that. And they were out there, and they were feeling very much an extension of the operating room. They were very much a part of the patient and the situation, and their level of stress was off the charts. So we have been designing in. Now, this is where Linda and Marsh comes in. Mercer doesn't do a lot with security and safety, but this is why we've got an opportunity and we're leveraging it to be able to bring in the capabilities that Marsh brings around security, safety, risk mitigation, and it really comes in handy, certainly in situations like this. But you can see the pre-work before we break down the roles for tasks, before we track and find and determine the percentage of time people spend doing certain tasks and what can be automated and what can be done at lower levels. It's understanding, what are we up against and what does this need to look like? And this is where we think the real success and the opportunity for improvement lies. Linda, anything you want to add to that?
Just one thing, you talk about security officers, but even just securities, we talk about workplace violence. I'll have a call later today with a health system that people are complaining and saying they're going to quit because there's a parking lot that everybody's car gets stolen. Again, the hospital parking lot, it sounds really, such a minor detail, but they're like, we can't keep getting our cars broken into and get stolen. And the resources are trying to manage that safety for everybody is a challenge.
Yeah. I mean, I spent a lot of time with University of Chicago medicine, and, the south side of Chicago, Hyde Park, that's no secret. And, going in their ER where they have, different entrances and different treatment areas because of the gang violence, and you can't mix the gangs in the same ER. Otherwise, really bad things happen. So, I mean, it's just kind of crazy. Actually, this is a really good segue to the next slide, Linda. This is
sure. So, and I know most we're out of time, but I can talk quick too. So you think about this picture, if you look at the number of recordable injuries that are tracked by OSHA, and people automatically think of oil rigs and drilling. But next slide, healthcare does have a higher rate of incidents of employee injuries. So, 6.1 incidents per 100 workers. And then, you see how many nurses claim to have been assaulted. We're starting to see some prosecutions happen. So these are things that healthcare organizations need to really pursue more of trying to manage that risk for safety, and that's for their patients as well. Next slide. And as we talk about total worker health, again, we were talking about their safety, their own health care, their rate of injury, but it affects patient care. And we're always focusing on quality and trying to manage the risk for poor quality. And so if you have higher turnover, maybe higher utilization of agency staff, more people kind of not engaged, that can affect patient satisfaction, ultimately their reimbursement. So it's a vicious cycle from there. So that's why we're really focusing on the total worker health and how to do more, as Ann mentioned, more than just having, pizza on Fridays or yoga classes, so that they really feel that they're being listened to, and that there's some strategies and mitigation steps to try to manage that work exposure, or they're feeling unsafe or their dissatisfaction, and whether that is working remote a couple days a week, managing their schedule differently. We're even seeing some organizations move towards more of a gig economy within their health system if they have some locations that are at a beach community, and they can do their own agency pool within their organization and rotate through there for staff that would prefer to work at a beach setting, a couple weeks a year versus being in their other city hospital. So it's about creativity and listening and engaging with the employees, and not just saying, here's a free cup and here's a slice of pizza. What more can you do to really understand what work they're doing and how technology could improve that, which it requires us to follow, or someone to see what their tasks are and try to manage that expectation going forward.
Yeah, this work here is going to absolutely change our understanding of health and well-being. You look at the work site, the work environment, particularly in healthcare, it is a social determinant of health.
Mm-hmm.
And the way the work is structured, the staffing, the hours, the exhaustion, these are all things that organizations are absolutely, I think, with this approach, going to be positioning themselves to think differently, work differently. And again, like a couple of the other things we've talked about, this has to work. Otherwise, there's so many things around this industry that just are not sustainable.
Yeah, 12-hour shifts may work for some people, but they may not work for everyone. And try to be creative and offer options too. I think that's at our last slide. Oh, yes, one more thing about the value-based care. Yes. So again, if you look at what we're doing on the value-based care standpoint, that's also a different strategy. And we talk about a strategy on a page. When we try to engage with patients and in healthcare workers to not just treat sick care, but be more proactive, have a different scheduling environment. It's a different job architecture. It's a different level of EQ. We see some of these value-based care organizations really studying EQ of their pharmacists, because they want to embed their pharmacists with the care team and try to get them to persuade different practice patterns. How do you engage with patients instead of just saying, here's your script, take it or don't take it? Is to really trying to change behavior proactively and not just responding to sick care. So the engagement is different, the work design is different, the teams are different, the architecture. So this is a whole new approach as we talk about value-based care and getting organizations to change that focus and that historical structure or traditional structure that they're used to.
Yeah.
Awesome.
Really cool. Fascinating. Yeah, well, thanks both of you for that presentation. I thought that was so interesting. And I just have one more question before we depart. Just kind of like on the tech implementation side and the fuzziness around AI. Like, I'm curious if you've seen any kind of specific use cases within kind of, those academic medical centers or whatever else, with maybe a specific vendor, like specific strategy that you guys thought was no brainer, like everyone should be paying attention to this kind of thing.
So in my experience, it varies significantly from administrative to clinical. And we're seeing more adoption, I should say, in the administrative piece now, while organizations are looking at more the clinical simultaneously. So as one program recently where they talked about utilizing AI to do a review of the medical record documentation to propose ICD-10 and CPT codes. And they said it's crazy accurate. Okay, so if you think of some of that traditional administrative type duties, some of the revenue cycle things, that's where we're seeing a lot more adoption and quicker adoption. But then there was one I was just reading about yesterday at Parkland Hospital in Dallas, where they're utilizing it to manage patients and who needs the OR first, and how that's being adopted with the clinical team. So it's clinical support information. Also for radiology, they joke about the 3 ologies that medical students don't want to go into now: dermatology, pathology, and radiology. It's how that adoption will be impacting that. But I'm seeing much more rapid implementation on the administrative side.
Yeah, well, I think we are
varies.
too. But I think there's still a lot of automation in the tank that can be done, that leads up to the AI, and I think that we're just still beginning to see organizations taking. I mean, we were able. I have permission to mention the name Duke, but we just took their patient intake and put it on an iPad, and all the patients do it themselves, and it's not done by a person on the team, and it's been enormously successful, freed up resources, freed up time, and improved what was a lot of mistakes that were being made. So it sounds so simple, but we love the AI, we are all over it, but at the same time, we're like, okay, look, there's a lot of other really, really good stuff that's operating now that people still need to take advantage of. So there's opportunities everywhere.
Yeah, absolutely. See you in Summers. Great to see you. Yeah, we're right at time anyway, so that's really interesting thoughts. I probably will have some follow-ups, and I'll send this kind of my notes that I took out to the group along with the recording. But thanks guys so much for this presentation, and really loved hearing kind of your perspective on this. And hope you guys have a good rest of your Friday. And if you guys have anything else to add to the recording, feel free to.
Well, just thanks for having us. This was fun, and let us know if you have additional questions.
Awesome. Thanks so much.
Thank you,
Have a good weekend. Thank you.
Bye.